Hi, and welcome to Detours Understanding Acquired Brain Injury. And this is second in this little mini-series, in our examination of irritability and aggression, anger, those kind of, they're all clustered together. So I want to look at these individually and talk about the different kind of how they are different and the kind of treatments, because the treatments are different. Irritability is more common after traumatic brain injury, but aggression occurs also. And I want to talk about also the behavioral and medication, the treatments with meds, separately. That's going to be another, kind of episode. But what is important regarding like aggression is that aggression is physical behaviors. It is acting out. Irritability is kind of more verbal in nature, or tends to be like snappiness, kind of showing anger, but it's not like hitting someone or something. It's not doing something physically violent. Whereas aggression is hitting a person, even self, aggression towards self, or breaking an object, throwing an object. That's aggression. Aggression is common after traumatic brain injury too. It's a little less common than, the irritability, but it's something that needs to be addressed. Spitting, kicking, biting, punching somebody, or even there are, you could argue, verbal aggression, things like that. But after traumatic brain injury, during the delirium phase, aggression is very common due to the patient being confused. And so you will get aggressive acting out. I had that during my, after I was coming out of my coma. I was aggressive physically, swinging towards whatever came near me because I had no idea where I was, what was going on. But it passed, and that is typical for delirium. And you also see that in patients who have comorbidities, other conditions that you see along with the primary diagnosis of brain injury. And so it is important to know, what's going on, as far as other problems. And it's smart. It's an intelligent decision as a provider to treat those comorbidities because it may resolve the aggression itself. And to know there may be something else causing it. It may not just be this patient is having a neurobiological malfunction problem due to damage. Maybe they can't communicate. Maybe they can't hear or see and are in distress and acting out. Maybe the patient needs to go to the bathroom and they can't express that need. Maybe they're having problems speaking. They can't talk at all. You would hope they would have been assessed for this, but sometimes some things happen. Maybe they're having pain because they're sitting on something hard on the wheelchair they're in or the chair they're in, and again, can't express that. So they're acting out. You see this with a lot of dementia patients where they're unable to communicate their needs and they become aggressive, and you fix that problem and it goes away. It requires observation by family members and people that are working with them to notice, oh, hey, this happens. And we're going to get into some of those details when we talk about non-pharmacological treatments, which tend to be the better choice when managing aggression. Now, there are some situations where a person's thinking is just so muddled that you do have to reach for the medications, or their cognitive abilities are so limited, again, that you have to reach for that. But that is not as common. Usually, it's something else going on. And I'm going to get to the neurobiology. And in some cases, they have basically lost the rule book in their mind, like when you do and when you don't, and that it's not appropriate to hit a loved one or get into a fight with a guy who's bigger than you. Some people just want to release their anger that way, and they pay for it. A lot of people who, get in this situation, it's just the way it works, and so it's something that has to be addressed. And so there are different ways, but let's dive in. First of all, aggression is something that, as the behaviorists put it, all behavior is communication, first. Second, it's something that can be measured. Behavior is not thought. It is something you can measure. You could put into measurable terms. What you need to be able to do is to capture these instances. Aggression is measurable behavior. And so you'll be able to write down and record these things, and we'll be getting into that. So what areas are involved? When you suffer a traumatic brain injury, give me a moment. Oftentimes, areas that are involved are the very areas that help you control and inhibit. Sphenoid wings are here. And I've talked about this before, but this region of your skull does serious damage to those very areas of your brain that help you kind of inhibit your impulse control. As far as like aggression and interpreting other people's behavior. And when you're in a crash, or when somebody hits you, or if you're choked, or if somebody smacks your head against the wall, or if you get hit to the side, you should, and as a victim of trauma yourself, many times, traumatic brain injury, it leads to damage to those very areas. And there are two areas that are typically associated with aggressive behavior. The big one is down here, the ventromedial areas of the frontal lobe. And both the right and the left areas of ventromedial lobe are those regions that help you judge risk and that help you figure out the threat level of somebody else's behaviors, figure out, is what they're doing dangerous, a threat? It contains basically the social rules. We call this the orbitofrontal circuit, OFLC, orbitofrontal lobe circuit. Damage here, you will see a person acting much more aggressively because they can't make sense of the threat level of somebody else, and they have trouble inhibiting their own aggression because trying to make sense of emotional sense, especially the right side. But both areas are typically involved and are necessary. But saying, no, I shouldn't do this. This is high risk to me. I shouldn't punch that guy who weighs, 400 pounds and 6'4". Not smart. Damage here. Neuropsychological studies show that these areas help us assess risk and help us understand the behavior of other people. So damage here. They also help us inhibit like primitive impulses, feeding, sex, and aggression. Necessary to say, nope, we exist in a society where there are rules, and this helps us to determine, no, not smart, should do, shouldn't do. And then there's our friend, especially on the left side, where we control executive skills. This is in the left dorsolateral prefrontal cortex. The right also plays a role in regulating mood and in helping us adjust for that lability that we often see. However, the left helps us come up with plans and figure out, like, I should do this, shouldn't do this. And damage here seems to play a role too, because it's like, what should I do next? And the linkage between these two regions of the brain often will lead to more likely to see aggressive behavior. Problems here leads to that emotional lability going between anger, depression, frustration. And so that is what we're looking at when we're dealing with emotional kind of imbalance. But these are the regions: left dorsolateral aspect of the frontal lobe, right for lability, the changeability of mood, the rapid changeability of mood, and most importantly, when we're dealing with aggressive outbursts. And it's important to know that this kind of aggressive outbursts are not instrumental. When I say instrumental, I mean thinking ahead, planning to, like a hitman. A hitman actually has a purpose behind their aggression. There's thinking, planning, decisions to be made. Soldiers, again, thinking, planning. People who have an aggressive job, there's a lot of thinking going on, a lot of planning. Yeah, it breaks social rules, definitely. However, there's intentionality there. There's planning within their own social rules, yes. So that's different. That's not what I'm talking about here. When you see frontal lobe damage, you're seeing a person who is prone to outbursts of anger, who is prone to outbursts of violence and hitting someone because they can't deal with it. They're not sure what's going on. Fear and anxiety and ego dystonic, something that is not to their benefit. Acting out that is harmful to them in the long run or short run. No justification for their behavior. No, hey, I did this because of this, and the other thing. Nope, that's not there. No excuses. They can't make excuses for themselves. So you can identify this kind of frontal lobe behavior, and it's not, those who have an aggressive job. It's a problem. It is a malfunction of the brain. And we will be talking next then about treatments. And there are things that can be done. Many times chemistry is also disrupted and can cause something that looks very similar, alcohol. And people with frontal lobe injuries, with orbitofrontal damage and dorsolateral damage, should avoid alcohol. It acts on the gamma-aminobutyric acid pathways, and it suppresses function here. So benzodiazepines, not good to use long term because it acts again, same pathways, and it suppresses GABA. Dopamine, excessive levels of dopamine can cause interference. So certain antipsychotics tend to work on dopamine pathway. Too much inhibition of the frontal lobe. This could be a problem. So watching antipsychotics. To a certain extent, antipsychotics can calm somebody down, but it, in the long run, can cause aggression and acting out. So it requires close and careful monitoring. We will get into pharmacological agents. Steroids can also cause an increase in aggression. Again, acting in similar areas of the brain. Drugs that are anti-dementia agents, which is interesting because a lot of patients who have dementia, frontotemporal dementia, Alzheimer's, Parkinson's, other frontal disorders, have Pick's disease, sepsis. Those disorders can have loss of frontal control and act aggressive. And UTIs can cause this because of disrupted chemistry. And so certain drugs that are prescribed, you need to monitor closely because if they act on GABA or dopamine or excessive levels of serotonin, can cause problems. So it's important as a physician prescriber to be aware of what you are prescribing for your patient. So just wanted to go over that. Next, I'm going to talk a little bit about those medications which can help, and more importantly, first-order therapies, which are applied behavioral analysis and some cognitive therapies and family group kind of approaches, which can be used to help patients with this. Because realistically, the best way to treat this is by working together and using Skinnerian type approaches. Because how we learn to control our aggression and more primitive impulses, things like that, is through reinforcing what was appropriate and withdrawing reinforcement from things which weren't. And so it matters that we use similar techniques to rehabilitate and help patients who have problems with this. It's the same thing with irritability too. But those are the areas we need to focus on and the techniques we need to use. Anything that can be learned, like controlling our impulses, can be rehabilitated. It's a lot of effort, I'm not going to lie, a lot of work, but it can be done. And it is important that we deal with this in a similar way. So yes, there's hope. Realistically, there's hope, but it does take work. I'm not going to lie about that. Rehab is hard, and it takes a long time. And there also will be healing, too. But it requires a realistic perspective, too. Have a good night. Bye.